Welcome, everybody, and thank you for joining us for this special edition TIF Talk. We're very excited to have our special guests today. We have Dillon Grove. If you've been following our Facebook page, you have actually been watching his journey. It's a very interesting patient journey, and we have him here live today to talk about GERD and the TIF procedure. Especially even more so special is we have his physician, Dr. Chang, Kenneth Chang, who is here with us this evening as well to talk about the TIF procedure and also GERD Awareness Week. So if any of you know, it is GERD Awareness Week. Today's the first day of GERD Awareness Week. And ironically, it's during Thanksgiving week when everybody likes to eat good food. But I want to thank you guys for joining us this evening and welcome both Dillon and Dr. Chang. Welcome to you guys both for being here. Thank you. So just a little bit about Dr. Chang, first of all. Dr. Chang's a board certified physician, GI at UCI Health. He's an internist and gastroenterologist who specializes in interventional endoscopy for esophageal and gastrointestinal disorders. He's the professor and chief division of gastroenterology and executive director of the H.H. Chow Comprehensive Digestive Disease Center and Health Institute. Dr. Chang is also the endowed chair of gastrointestinal endoscopy, endoscopic oncology. Welcome, Dr. Chang, and thank you for being here with us this evening.
Thanks, Andrea.
Thank you. And then Dillon, again, if you've been watching his journey on our page, he is from Carpinteria, California, or Santa Barbara. Where do you like to say you're from?
Yeah.
Santa Barbara, California, which happens to be my hometown. But anyways, my name is Andrea Millers, and I'm with Endogastric Solutions. And again, this is our TIF Talk. You can ask us any questions at any time during this live event, and we will do our best to answer all of the questions that we can this evening. So we're going to go ahead and kick this off. You got to see a little intro of Dillon's journey and his story, but we're going to ask him a little bit more about how and talk a little bit more about, his struggles and how he ended up finding Dr. Chang and eventually having the TIF procedure. But before we go into that, I'd like Dr. Chang to kind of explain what GERD is. And since it is GERD Awareness Week, you can kind of talk a little bit more details about the scientific explanation of GERD.
Sure, Andrea. I happen to have my esophagus with me right here.
Perfect.
So GERD simply is when stomach contents, when fluid, acid from the stomach actually refluxes and splashes back into the esophagus and causing patients troublesome symptoms such as heartburn, regurgitation, and many other types of symptoms. So either symptoms or complications of the reflux. So the complications could be strictures and ulcers and precancer and cancer. So again, GERD is pathologic reflux of stomach contents into the esophagus, either causing troublesome symptoms or complications.
Perfect. Thank you very much. Now, Dillon, talk to us a little bit more. I know you struggled for many, many years with GERD. Can you kind of talk to us about your, how did it impact your life? Your relationships, work, the activities that you did. Describe kind of the things that, and also for how long were you suffering from GERD?
Yeah, so I first started noticing that spaghetti sauce affected my stomach and esophagus when I was pretty young, like less than 10 years old. And then getting into high school, I noticed the heartburn. The heartburn was really, really bad. Sleeping, it would hit me in the middle of the night, and then it just got worse and worse. And the things that affected were I played baseball in high school, and I always had to make sure I had Zantac. And because at that time I didn't think I needed Prilosec, it was just a short-term thing. So I think the biggest thing when I was younger was always the constant need for medication. When I went out of town, when I went away for a weekend, when I was going somewhere for a day, it was just like a Band-Aid, because I would eat what I wanted to eat, but I always had to make sure I had Zantac with me, or Tums. So that was stressful. And then as I got into my 20s, and it got worse, and I got onto omeprazole and those PPIs, it was the same thing with the medication, but really I started to feel really kind of gross as a person, which I know is a weird thing to describe, but dry mouth, acid taste in my mouth, burning throat, chest pain, and it just made me feel like that's what I was exuding to the people around me, you know, in my relationship too. Like I felt like I didn't want to be too close because I might taste funny, or, you know, because I was tasting something funny. And then talking, the dry mouth affected. I'm a counselor at work, so I talk a lot. I'm on the radio too, so I was always having, you know, heartburn and dry mouth, and just the symptoms got bad where I had to cancel things. And yeah, that's the easiest way to explain it, I guess.
Yeah, yeah, yeah. And Dr. Chang, is that pretty common, all of the symptoms that he was explaining, you know, the dry mouth and regurgitation and just, you know, taking all their meprazoles, you know, all the medications? Is that the typical kind of complaint that you hear from patients that come to see you?
Yeah, I mean, there are typical symptoms, but you know, when you meet one person with GERD, you meet one person with GERD. The manifestations can be quite broad, and people don't really appreciate the kind of symptoms one can have that are what we call atypical. So the more typical or common symptoms, heartburn, so there's burning sensation, you know, behind the breastbone, regurgitation, the feeling of stuff actually coming up and kind of retasting it in the back of your mouth. We call that water brash with regurgitation. So those are more typical, but the atypical are hoarseness, throat clearing, a change of voice, asthma, shortness of breath, bad breath, what we call halitosis. These are, or chest discomfort. Those are on the atypical side. And a lot of times it's often misdiagnosed or underappreciated that this actually can be related to GERD.
Yeah, yeah, great point. So Dillon, I know, you know, we've kind of chatted and we've interviewed you, and I know you had many hurdles that you had to jump in order to finally, you know, find the right doctor and get the treatment option that you wanted. Can you kind of, and the reason why I want you to share this is because I know that, you know, a lot of patients are out there, and it's GERD Awareness Week, and the whole reason why we have these TIF talks is to educate potential patients and let them know there's other options out there. And then more importantly, that, you know, you need to be an advocate for yourself, and find what treatment option works best for you. You know, not all treatment options work for everybody, but kind of talk a little bit about, you know, your location. You were in Santa Barbara, and, you know, you kind of had a GI, you have a couple of physicians that you're working with. They put you on medications, but you just felt like that's all I kept getting was just stay on your medications. Can you talk a little bit about that?
Yeah, of course. So we always take our problems initially to our primary care doctors. Most people do. So that's what I had done. And a primary care physician prescribed me omeprazole. And, you know, there was a long-term goal that I would get off it at some point, but that point never came. And it was just continue to take omeprazole. And when the symptoms started to get worse, I was told to up the dose of my PPIs and add an H2 blocker, which I, again, didn't know there was another solution. This was the only solution I was being offered, so I did that, and the symptoms continued to worsen, and I was really stuck. You know, and so then I got referred to a GI doctor, and had an endoscopy done and was given the same solution by the GI doctor as my primary care physician in to take the same amount of medication. He told me to up my H2 blocker by 10 milligrams. And I remember sitting in the room after and telling him, well, I don't think that's going to work because I'm not like something doesn't feel right. And he said, well, call me in a couple weeks if it doesn't work. And so again, yeah, I mean, that's basically the hurdles is like just I was offered the same solution by multiple doctors. And I didn't know that there was anything else to do. And I like what Dr. Chang said about, you know, those symptoms not being related to GERD. It's like people are like, oh, you just have heartburn, you know, it's okay. And if for somebody who understands that it's not just heartburn and that all the medication that people without chronic GERD can take, you know, a TUM will make it go away. But if you have chronic GERD, one TUM does absolutely nothing.
Yeah.
So,
yeah. Dr. Chang, can you talk a little bit about, you know, what medical therapy does versus, you know, a surgical option with the TIF procedure and why, you know, PPIs or medical therapy is just kind of band-aiding the problem. If you can kind of discuss that a little bit, that'd be great.
Yeah, so you know we talk about the underlying mechanism of GERD, and as much as we've known about why GERD happens, we've actually learned a lot in the last 5-8 years, a lot more than we ever have, and that has to do, going back to this model, that there's a valve on the inside of the esophagus called the lower esophageal sphincter, which normally is closed when we're not eating and swallowing, and that prevents the acid from splashing back. The newer thing is, you know, the diaphragm muscles, which wrap around the esophagus, also act as a external valve, and that works together and in beautiful synergy with the inside valve and the outside valve working together. When the outside valve is stretched open, it can result in a hiatal hernia, meaning the stomach then can come up into the chest above the diaphragm. And we know about the hiatal hernias, but what we haven't appreciated until more recently is that even when you don't see a hernia, the diaphragm muscles can be loose and the stomach can slide up and down, and that synchrony, that synergy between the inside and outside valve is disrupted and not coordinated. So when we see a patient like Dillon, you know, we start looking at what's broken. Specifically to this person, you know, what isn't working? Is it the inside valve that's loose? Is it the outside valve that's loose? Is it both? Is there a vertical component? Is there a horizontal component? Once we understand what's broken, then we're going to fix only that which is broken. We don't want to underfix and we don't want to overfix. So really it's an anatomic, if I could say it's a plumbing problem, it's a plumbing problem. And so by changing the pH of the water that's going through the pipes is only a partial solution in many cases. Now, PPIs are great medications. They work in the majority of patients because it neutralizes the pH of the acid in the stomach. And so when the stomach fluid splashes up, it's less irritating and symptoms can be really well controlled for a lot of people on PPIs. So I don't want to throw PPIs under the bus whatsoever. But in a lot of people like Dillon, done the whole PPI route and plus H2 blockers, plus diet, plus behavioral modifications. They've done all that, and they still have what we call refractory GERD that's still breaking through because the physical reflux is still very bothersome. And so at that point, we really want to look at a more anatomical solution. And so that's when we did the workup and realized that even though he didn't have a large sliding hernia that was obvious, his inside valve was quite loose, his outside valve was quite loose, and we know we needed to strengthen and tighten them both. And we did that in a combined procedure, including the TIF.
Yeah, I really like the point that you made, kind of like that personalized approach. For every patient, there's a different treatment option. And that, at the end of the day, that's how it should be, and how, you know, the physician should look at each patient. that way. So I do like that, to your point. Dillon, I know you talked a little bit about you even had to change. So you changed your GIs after, you were frustrated with their initial kind of, not initial, but preceding treatment options, stay on the PPIs, up your dose and whatnot. You had mentioned to me that there was some struggle, like you even had to like change your insurance to be able to go see Dr. Chang. Tell us a little bit how you learned about Dr. Chang and the TIF procedure and how you ended up going to Dr. Chang for your kind of consult.
Yeah, so luckily my dad has known Dr. Chang for a while and worked in the industry with him. So he suggested that I go and see Dr. Chang and go down to UCI. And so yeah, I did have to change my insurance over to a PPO, which, was doable. So I did that. And I mean, it was great. It wasn't too long after I was able to go down for the diagnostics and get the process started.
Yeah, fantastic. Do you see, Dr. Chang, a lot of patients that come even outside of your local market that come to see you?
Yes, and it's actually interesting. As awful as COVID has been, it's forced us into the realm of telehealth, and a lot of our consults are now telehealth. So just today in my clinic, which was virtual, calling in from different parts of the country. One lady from Florida called, and so we're having a farther reach in terms of being able to help people from a distance. And whether or not they travel to come here for their procedure or they wind up finding someone locally, that's fine. But at least we're able to give them some valuable information through this virtual consult.
It's fantastic. That's great. So Dillon, can you talk to us a little bit about, the testing, and I'll have Dr. Chang kind of talk about what you had Dillon go through, but I know it's a little bit different because Dillon, you had an initial GI where you got your EGD testing and potentially, I don't know if you had your pH or Bravo or what other testings you had there, but then you switched over to Dr. Chang. What was the process in the diagnostic workup until you had the TIF procedure?
Yeah, so my original endoscopy from the original GI doctor was it was just an endoscopy, and Dr. Chang, I think it was a couple images really, and then so we did a video consult first, and then scheduled the diagnostics for about a couple weeks out, and then the hard part about that was I had to go off medication for maybe 10 days or a week before, something like that. The first time I started interviewing for all this stuff, I was actually off of medication, and it was really hard for me to talk. I kept having to take breaks on the set and everything because I was having really bad symptoms because I was off medication. But that's what needed to be done, which is fine. So I got down there and went to sleep for the endoscopy, and coming out of the endoscopy, they were able to tell me exactly what was going on, exactly what the problem was, exactly what they were going to do to fix it, and what I needed to do until then. And I felt very comforted, and I was like so relieved. I was so relieved. And then I had to do the Bravo test, which is basically like a little strap, like necklace type thing. Looks like a Game Boy kind of. And just wear it around your neck mine was 48 hours. And they encouraged you to eat a little more spice and stuff than you normally would to kind of, get the most natural measurements or whatever. So I did that, and there's a couple buttons you press on it, and that was pretty uncomfortable because I was eating food that I hadn't ate in years, trying to, and it was press a button for different symptoms like regurgitation, heartburn, chest pain. And so I did that, and then dropped the device back off, and that was really the experience of the diagnostics.
Yeah, maybe I can comment on that, Andrea, from my perspective, having been doing this for 30 years. We've evolved quite a bit. What Dillon describes is kind of the best of the best one-stop shop diagnostic, where in one sedation, he's comfortably sleeping, We did 4 different tests. And when he woke up, he was none the wiser that we did all these things, you know?
Yeah.
It used to be we would do an endoscopy, right? And then separate from that, we would do a pH catheter, which was essentially a little small noodle-sized catheter. It went through the nose and parked in the esophagus, and he'd go home with it for 24 hours to measure the amount of acid, and that was quite uncomfortable. So that's two procedures. There's a third procedure called esophageal manometry, which is a different catheter that goes down, and for 20 to 30 minutes, it's sitting in the esophagus, and we have patients swallow to see how well the peristalsis is in the esophagus, how strong the esophagus can actually move things down, because if we're planning to tighten the lower valve, we don't want to tighten it too tight relative to the strength of the patient's squeeze. So that manometry procedure is also not the most comfortable for patients. So that would be procedure number 4. So we took all of those procedures and we put it all into one. So you had the endoscopy. Instead of a wire pH, you had a wireless pH, a tiny little microchip capsule that we just place in the inside of the esophagus, and it's designed to record for 2 days, send that data to a wireless little receiver, and then it falls out and it goes through the poop, and that's gone. And then so nothing through the nose. And instead of the manometry, we had another test called EndoFlip, which we do while you're asleep. We can get a lot of those measurements while you're under, and then that comes out. So when you wake up, there's nothing coming out of your nose. You had one nice sleep, and we did all the diagnostic work. And we could find out pretty much everything we needed to know about your physiology. So then we can tailor make the treatment towards exactly what's defective.
Yeah. That's perfect. So especially even from him coming from 2.5 hours away, he was able to come up there and get that all done, and you already kind of had a plan of action for Dillon. Speaking of your plan of action, let's talk about the day of the procedure. I know we have some filming of you the day that you went in. I know you were somewhat nervous. Talk to us a little bit about how you were feeling then, and were you excited? I know you had been off your PPI, so you kind of were struggling up until you went in to have your procedure, but talk to us a little bit about how you were feeling the day of.
Yeah, I mean, I think anytime a person's being put to sleep under anesthesia and getting operated on, there's going to be a little bit of nervousness. So I had that, but there was also a sense of excitement and relief, because I was finally going to have a permanent solution to this thing that had been plaguing me for years. So it was like nervous excitement, nervous because it's just, going into surgery. It's a nervous thing for anyone. But very much anticipating coming out on the other side and beginning to live life without chronic reflux.
Yeah.
That's really and Dr. Chang and his whole team and everybody at UCI I can't say enough about how nurturing they were and just how comfortable I was and how much everything was explained to me. And I felt very safe and cared for pre-op, during, I was asleep during, and afterwards. So, yeah.
So did you spend the night there, Dr. Chang? Did he stay the night after his procedure?
Yeah, it was a one night, what we call a 23-hour observation. So he does stay overnight and discharged the next day.
Okay. And that's typical he had both a hiatal hernia repair as well as the TIF procedure, correct?
That's right. He had the combined procedure.
Yep.
So that is an overnight stay. When we do just the TIF by itself, so in those folks who just have a loose inside valve and that's all they need, we can do the TIF alone. And those folks can sometimes be discharged, several hours post-procedure. Sometimes we keep them overnight, just depending on their age and their situation.
Sure. Okay. Wonderful. We have a couple of comments or questions, so I just want to make sure we get to that before we talk about kind of life after TIF and how you're feeling today. So let's see. Hold on, I'm sorry. I have to read through all of these. This is Matthew James is saying, I'm 7 weeks out and I had thrown up about a week ago since I've been having worse symptoms. Before this, my progress had been well. Very interested in this procedure. Oh, they were just making a comment. Let's see. I saw a question in here. Oh, can you tell me roughly how much of my regurgitation and heartburn symptoms will go away and what can I expect? So I'll throw that one to you, Dr. Chang, to answer kind of what most typically patients feel after the TIF procedure.
Yeah, so everyone responds obviously differently. But if you look at the data, look at the published literature and what we call level 1 evidence, that's the most rigorous clinical trials where there's randomization and control and all of that. The statistics show that 87% of patients who undergo the TIF procedure can be completely off their PPIs and have great control of symptoms. So it's not perfect. No, I don't think anything is perfect, but it's a very good outcome as far as when we look at medical outcomes. And in Dillon's case, he had the combined procedure, and they're typically with the combined procedure, we're expecting 90% or higher in terms of similar, great control of symptoms and being off the PPI medications.
Yeah, perfect. So talk to us, Dillon, about your recovery. Was it difficult, as far as everyone talks about the diet, right? How was recovery after the TIF procedure for you?
I will say that I underestimated it. I didn't think that it would be as trying as it was. Not that it was anything major, but I definitely will say that for everyone watching is that it was the diet. The liquid diet is a little bit more difficult to adhere to than expected. But the pain was not. I mean, they give me some pain medication that I only took for about 2 days in liquid form, so the pain wasn't really severe in the incisions and all of. Well, I had the incisions because of the hernia, but the pain in my abdomen and diaphragm area was not severe at all. After about a week, it was okay. Gas and bloating, definitely. I know that there was air inside of me that was moving up my body into my shoulders. My shoulders were that's a really weird feeling, but a little sore, kind of feel like pressurized. I think it's the easiest way to say it is your whole digestive system and all that stuff working down there is a little shocked and out of whack. And I think there's an adjustment period, and really just adhering to the diet, to not push anything, and be prepared, go shopping before.
Yeah.
All that, have all those things ready. But overall the recovery, it was okay. It wasn't too bad.
Yeah.
And they give you everything you need to know. And I want to say a special thanks to Jamel, Dr. Chang's nurse, because she answered my emails any time of the day and night.
That's great.
Awesome. So yeah.
That's wonderful. Dr. Chang, can you talk a little bit about what your protocol is, post-op protocol after the TIF procedure? And
Yeah, so for those who just need the TIF by itself, the post-op instructions are a little bit more shorter and quicker to get back to steak and lobsters. So the main thing is that when we put these fasteners in and create this beautiful valve that was our original design, when we put things back in order, so to speak, it takes time for that to heal. And if we overstress those areas and stretch them out before they've had a chance to heal, then we could create a situation where it's loose again before it had a chance to more or less solidify. So typically it's about a 4-week time to heal. And so during that 4-week, we start with what we call full liquid. So full liquid means smoothies, protein shakes, so you won't get malnourished on a full liquid diet. And we do that for about a week or two, and then we switch to a more soft puree diet for the next 2 weeks. So 4 weeks of that, and then at 4 weeks, you can pretty much eat whatever you like, chew well, and so on. When we do the combined, so Dillon had the combined inside valve, outside valve, that extends a bit longer, 4 to 6 weeks. Again, a lot of it is common sense and judgment and how well you're doing, how well you're tolerating it. So it's a little bit longer because now we've done more work. We've reconstructed the inside valve, we've tightened the outside valve. So it takes a little bit longer for everything to heal and settle back to equilibrium.
Fantastic. Wonderful. I do have a question that just popped up from Martin. He's asking, does this work for LPR?
Yeah, so LPR is laryngopharyngeal reflux, and that is diagnosed by symptoms of cough, or sore throat, hoarseness. And so LPR can be caused by irritation coming from below, and LPR can be caused by irritation coming from above. So this is a turf battle between GI and ENT, right? ENT will say, oh, it's a GI problem, go see GI. GI said, no, it's an ENT postnasal drip problem, go see ENT. So it's kind of like this. But all kidding aside, LPR can very much be related to GERD. We just need to make that connection. And so it does take a very intentional workup, including some of the things that we talked about, to make that correlation between the symptoms that we're experiencing in the throat area with reflux. Once we can make that association, then we're on the trail to treatment, and we can expect the LPR symptoms to get better when we fix the underlying GERD anatomy. However, there are situations where it's not related to what's going on below. It truly is, postnasal drip, or there are some functional things that can cause these similar symptoms. And so even more so with LPR patients, we have to be extremely diligent in the workup to make sure that we're barking up the right tree.
Right. Yeah, that makes sense. Thank you. So Dillon, I do have to mention this, and we're going to talk a little bit more about, after the procedure. But when I first met you, I think you were on your 2 weeks off of your PPIs or your medication, and we started doing your interviews with you. And I feel like the person that you were then, and that was what, 2 months ago about now?
Yeah.
Yeah.
July, August, mid-August, July.
That Dillon that I had met originally to the Dillon that I know and see now, especially like with your videos that we've filmed, even just talking to you today, your whole demeanor is totally different. I can just see it, like inside, you're just happier. And I'm not saying that's just because of the TIF procedure, but I do notice a difference. You seem really miserable when we first met you, and really suffering. So it's nice to see you now today, recovered. Kind of tell us a little bit about, what is life like now? Now that you've actually had the TIF procedure, you've recovered pretty much for the most part. You're what, 9 weeks out now? Tell us.
I had surgery on August 21st, so however long it's been since then.
So how do you feel now? Tell us a little bit about what you couldn't do then, you can do now. Just tell us how you're feeling.
Thank you for all the kind words. I appreciate that. I definitely was suffering, and I was not happy, and I was stressed and anxious all the time. Everything involving food and my day-to-day living and diet and everything was affected every second of the day, all the time. And now, I mean, we were talking before. I don't even think about it. I mean, it's really just, it's really, I don't know how else to say it. I don't. It was the first thought when I woke up in the morning, and it was the last thing I thought about when I went to bed, and I thought about it all day long. And now I don't even think twice about it. I mean, it's like I don't have any symptoms. I drink coffee every morning. I eat, spicy food. I don't have to worry about my diet. I just started doing exercises and working out again that involve a lot of up and down movement. That's not affecting me. I mean, that's the best way to say. I just don't. It's not an issue. I don't really think about it. It's just,
Wow.
business as usual every day. So, yeah, stress free in that aspect.
That is amazing to just know that you're not thinking about GERD anymore and in your daily life. I guess you could say that's quality of life that you got back.
100%. Yes.
Yeah. Yeah. So Dr. Chang, is that typically, what's the response that you usually get? How do you feel when you hear Dillon say that, that you're basically the reason why he doesn't have to think about GERD anymore? Must feel really, really good.
Yeah, it's music to my ears, Dillon. It just makes me very, very happy to hear your story and that I could be a small part of it. It's typical for patients to have a significant improvement such as yours, but your story in particular really makes me feel warm inside because you're so young. First, it's quite unusual for someone so young to have such bad GERD. I've seen it, and typically these are kiddos who spit up all the time when they were young and have had issues, even growing up. The social aspect and the physical aspects and so on. But to do an intervention that can be this dramatic in terms of affecting your quality of life, so that you can not think about this chronic GERD that you've had from when you were very small till now, and that you can go on and live life and live it to its fullest. Um, I have children your age, literally, children your age, and to see that dramatic of a change in terms of quality of life would make any parent crazy happy. So
Yeah.
I'm crazy happy for you.
Oh, that's great. So
Thank you. Thank you.
that's wonderful. So again, we are kicking off GERD Awareness Week, trying to educate, the community and, potential patients out there that are suffering with GERD or chronic acid reflux. And really the intent of these TIF talks is just to educate, let people know that there's choices and there's options out there, and that you can advocate for yourself. Do you have any, in closing, if you will, Dillon, is there any advice that you would give, any patient that's suffering or going through kind of the same things that you've gone through? Do you have any advice for those people?
Yeah, I would say don't stop searching for relief until you find it. If what's happening in your treatment in your life is not working, then there is another option. And that would be my best advice. And just that I feel for you. I know how much I know how disruptive it is and how it makes you feel, and it's not a fun thing to deal with. So I would say just, yeah, to know that there is a solution in the TIF procedure, and that it worked for me totally, and to seek that out. Contact whoever you need to contact and take the actions to seek out the doctors and the right people, and take the steps necessary to get a permanent fix, and don't let anyone hold you back from finding that.
Yeah, that's awesome. Thank you. Dr. Chang, do you have any advice to the community or the people that are out there watching today?
Yeah, sometimes these awareness things I feel like they're a bit hokey, but I think there's extreme value, really, because this is awareness, right? So we're sharing our story, Dillon's story, his journey, and someone listening, to this is going to be now aware that, oh, okay, GERD is not just PPI, or GERD may have solutions, or there can be individualized, tailored treatment specific to my condition. And now with our ability to access information, it's no longer the doctor you happen to be assigned to and the area you happen to live in. You have the whole country, literally, that you can search and get expert advice, get into chat rooms and see what other people have. And physicians are more apparent and transparent, and we're graded, and so you can get access to a lot more information and get good quality advice. So I agree with you, Dillon. This awareness is important. Your drive to not be satisfied with what was told to you, and you continue to pursue getting more information. And this is paying it forward to other people. This is creating that awareness and paying it forward. So thank you.
Yeah.
Thank you.
Yeah, wonderful. Well, if you're watching and you're wondering where you can find a doctor that offers the TIF procedure, you can go to gerdhelp.com. There is a physician finder on there, and you just put in your zip code, and you'll be able to find someone near you. Or you can, call Dr. Chang's office at UCI and do a telehealth initial consult. So there's lots of options, and I know right now, it's a little tough with, kind of the elephant in the room with COVID and whatnot. But like you said, fine institutes like UCI, they're doing things such as telehealth, and also, testing before you come in for your procedure to make things safe. That's one other thing I was going to ask you, Dillon. Were you concerned at all, with COVID going in to do your procedure, or, did you feel real comfortable, obviously, because UCI is doing all the right things, if you will?
That's a good question. No, they laid it all out to me before I even got there, over the phone, and it was all laid out for me. I was tested, prior to anything starting for the diagnostics, and I was required to and I got a COVID test before the surgery. Everyone wore masks the whole time. I mean, it was all told to me. It was all transparent, and I felt very, very safe. Yes.
Yeah. Good. Do you have any comment on that, Dr. Chang, about people being kind of apprehensive of coming into the hospital for elective procedures right now?
Yeah. So I think we can underreact and overreact to COVID, and I hear stories both ways. But what breaks my heart are folks who really need medical help and attention, and they're like, no, I don't want to go to the hospital and get COVID and die. I'm going to hold off. And then 3, 6, 9 months have gone by, and now their cancer has gone to an unresectable stage. And so it breaks my heart when people overreact to COVID, because literally the hospitals like ours are probably the safest place to be in COVID pandemic, safer than a restaurant, safer than the supermarket, safer than wherever, because of all the steps that we take. This is my workplace. I come here, I spend 10, 12 hours a day every day, and I come home to my family, and I feel safe. Every staff is tested every shift. We wear N95s. Every patient coming in gets tested before they walk in the door. We take all the precautions, and so we feel that this is a very safe environment. Obviously, I'm here every day, so I must feel it's pretty safe.
Yeah.
but I understand the concern coming in. If you have a super elective procedure that can wait a year, then wait. But if you're having symptoms and there's something going on, I would say, please, the risk of getting COVID in the hospital is not worth the risk of what you're not taking care of. Yeah.
Yeah, perfect. Well, I can't thank you both enough for joining us this evening. I know that us at Endogastric Solutions really appreciate you taking the time to educate the community out there. And I know the people that are watching really appreciate it. We've got a lot of comments here thanking you guys for your story, Dillon, and then your expertise, Dr. Chang. So again, thank you everybody for joining us this evening. We really appreciate it. If you have any other questions, feel free to post them on the comment section. We'll do our best to answer them in the future. And then also we have another TIF talk. We usually do our TIF talks on Tuesdays. So we will have a TIF talk tomorrow with another physician. So if you want to join us and listen to another perspective from another physician, please join us. But because this was a kind of our kickoff for GERD Awareness Week, we wanted to bring Dillon and Dr. Chang in today. So thank you everybody for joining us this evening. Dillon, thank you. And Dr. Chang, thank you very much. Please stay safe, everybody, and have a great evening.
Thank you.
Thank you.
Hi, Dillon. Hi, Andrea.
Hi, Dr. Chang.